So let's get very basic, because I think it'd be useful for us to get on the same page. And I think things are really changing. So let's see where there's agreement and where there may be disagreement, and about some very basic questions. What is addiction? And how do we understand it? I think these are key to how we address it. So we may disagree on all of this, but I think it's important for each of us to, if we're going to be effective in our jobs, in our, wherever we're sitting in this community, these are important questions for us to answer. I mentioned scientific revolution, paradigm shift. Some of you may remember there was a day when humans thought that the earth was flat. And then there were a few scientists who suggested that actually the earth was round and it revolved around the sun. One of them was Galileo. And he died in house arrest because he was considered to be blasphemous. He was seeing a new paradigm that challenged the old paradigm, and the old paradigm got scared. And that's what happens frequently. I think we're in a similar place in the addictions field. We're moving from what I think of as a simple disease concept to more complex ideas and solutions. And I think this is happening in our world, worldwide, in many different areas. From this biological disease model, which is frequently a camouflage for moral and criminal models. After all, if you actually believe that addicted people have a disease, why do we incarcerate them for the behavior that we're calling the disease? So actually, we're very mixed. The culture is very mixed and confused about what this actually is. We're going from a categorical view that is either you have it or you don't, you're addicted or you're not, to what I think of as a spectrum view. In the DSM-5, the Psychiatric Diagnostic and Statistical Manual, we're now, in the States, we're now talking about substance use disorders on a spectrum, which I think is much more close to what we see in clinical practice. People move up and down that spectrum. And people vary on multiple dimensions. It's not just the substance use. There are multiple dimensions, which I'm going to touch on. So we're really talking about a new view of substance users, substance misuse and addiction, and a new approach to treatment, a new view of treatment that emerges from these new ideas. So I would say this really, to bring it down to what we've been talking about, is reflected in a shift from abstinence only to harm reduction therapy. Now, I've said before, I think that the dominant addiction model might be the problem. Society is dominated. This is a lot of words. But what I think of as an anti-meaning, one-size-fits-all, abstinence-only, reductive disease model. That's a lot of words. It's a particular addiction recovery narrative. One size fits all. The disease is permanent, chronic, progressive, only arrested by complete and total abstinence. And if you believe that, then you will only support abstinence-only treatment. It just follows from that narrative. It's closely linked to moral and criminal models, and it informs this abstinence-only treatment system. And unfortunately, on the mental health side, many mental health professionals have also bought into this and believe that you cannot treat an active drug user in mental health care. So, what do we see? The addiction treatment community won't treat active drug users, and the mental health community won't treat active drug users. So where do they go for help? And what message is sent to the drug user? You're not ready for treatment. The only way to get ready is if you embrace abstinence. I think this is a very dangerous model, framework. and it keeps people from seeking help, like the patients that I mentioned. So models are going to shape our perceptions and inform our treatment approaches. Now, here's another thing I want us to consider. There's like a battle. There are battles that go on in our field between the people that think addicts choose to use drugs. It's a choice. And other people say, no, it's a disease. It's not a choice. Others say it's a habit. It's a habit. It's a bad habit. Others say, actually somebody recently said to me, using the word addiction is actually using a four-letter word. It's really like a terrible thing to say about somebody because of all the baggage associated with that. Others say it's a meaningful response to suffering. I think our last psychiatric nurse was talking about that, dealing with coping, suffering. So a lot of different ideas, and unfortunately, frequently people are fighting about these ideas. And I'd like to suggest maybe each one of them has some merit for some people. So let's try to stop the battle and see. Now, even this, does an addict actually exist? Is there such a thing as an addict, or is it really a dehumanizing social construct? That is, that we've created this idea that somebody is an addict, and we then see them with all of these presumptions: diseased, incapable of rational thought, powerless, selfish, all of those stigmatizing presumptions. And there are frequently a lot of these statements that are made about addicts that are based on that. Keep it simple, stupid. Addicts suffer from the disease of terminal uniqueness. Take the cotton out of your ears and put it in your mouth. These are statements that are frequently made in the recovery community that presuppose something about this human being that is struggling with substance use. They're all in one camp, and it's usually a pretty bad camp to be in. How much of the addict's behavior then becomes a self-fulfilling prophecy? They keep telling me that I'm selfish and that I'm powerless and that I, am irrational and I can't be trusted. So maybe I should just act like that, particularly since they won't let me into treatment because I'm not ready to stop using. So on the other hand, some people that I know, I taught a class, this certificate program last year, and one of the students said, I love the idea that I'm an addict. It really helps me, in my recovery. So all of these ideas, I think we need to be questioning and be curious about and kind of expand our conversation about. So what is addiction? Well, most people can agree. And I actually asked a number of leading people in the field, and they basically all, William White is an Alcoholics Anonymous scholar. Gabor Mate wrote this best-selling book, In the Realm of Hungry Ghosts, and William Miller is the founder of motivational interviewing. They all basically told me very similar things. Addiction is characterized by the experience of craving, compulsion, loss of control, and an inability to stop. That seems to be a phenomenon, an experience and behavior that most people agree is what we call addiction. The question is, how do we understand it? And I think that that's where people differ. And we have many different models. Now, I also said part of this paradigm shift is from this binary to a continuum model. Either you have it or not, or substance use is on a continuum. So that from this point of view, arguing about whether you have the disease or not doesn't make any sense. This is something when in the old days in my treatment programs, people would get into battles with people. You have the disease. You are an addict. They would say, no, I'm not. Yes, you are. No, I'm not. So why argue about it? I mean, if we get away from this binary way of thinking about it, it's more relevant than to ask, in what way does drug use affect your life? How's it working for you? How's it working against you? we can get into a much more nuanced assessment. And we can also be thinking about early intervention. Okay, you don't have those full-blown addictive qualities, but in some ways it's problematic. Maybe we can intervene where you are concerned. And that's where the harm reduction framework opens everything up. And also, people have different issues along that continuum. Now, I also talked about varying on different dimensions. People differ in the pattern of use, in the problems associated with use, in the physical adaptation. Some people have tolerance and withdrawal. There is physical dependence. Many people don't experience that. There's behavioral dependence. You need this to get to that party and be able to talk to that girl that you wanted to talk to. So people depend on it for coping. Cognitive impairment, physical impairment, medical harm, motivation to change. Some people are totally unmotivated. Some people are concerned and motivated to think about it. That's the stages of change, which we'll talk more about. And I would add that people vary on the benefits, the positive functions, which we don't talk about enough. If we don't talk about what you like about using, how can we talk about what needs to change for you in order to give up that thing that you like, that's working for you in some way? And also multiple meanings. It's not just coping, it's all sorts of things, which we're going to dive into that complexity in a minute. And also awareness dissociation. Some people really know, I use when I feel anxious. I use when I feel despairing. I use when I'm angry. Other people are mystified. I have no idea why I use. So I did a talk a few months ago called When Simple Isn't the Solution. And I have to tell you, when I started getting into all this complexity, I started getting very confused. So if you're all sitting here feeling confused, I'm right with you. It's like, I want us to get confused with all of these different ideas and then figure out how do we make sense of it. So competing models, weak will, the drug made me do it, the devil made me do it. There are people that really believe that. Character defect, genetics, environment, addictive personality, anyone susceptible. These all are held by some people. Okay, now let's go through the models, and then we'll get to the meta model. Personal choice. Is addiction a choice? Some people actually think that this is a valuable concept, that it has to do with human rights and the right to choose to use a drug or not. And to some extent, there is choice. Yet many people feel that they have no choice. They feel completely out of control. The spiritual model. People are powerless to resolve their addiction on their own and need the help of a higher power. There are many, many millions of people that have recovered with the spiritual program of Alcoholics Anonymous and find that view to be very affirming and very useful. On the other hand, there are many people that have trouble with the concept of powerlessness, particularly many people that have experienced trauma. I don't want to accept that I'm powerless. That was really what was involved with the traumatic experience I had. And some others went through AA and feel like it really hurt them. So how do we make sense of these different camps that have different points of view about the spiritual piece? The disease model I've been talking about, it's based on the work of a man named Emil Jelinek back in the early part of the 20th century. He did a survey of AA members, and he came up with this model. It's permanent, chronic, progressive. It informs abstinence-only treatment. The commitment to abstinence, this is what I've been talking about, is often necessary to get into treatment. But it's not supported by evidence. The evidence that I shared at the beginning, that most people it doesn't appeal to most people. Now then there's the contemporary brain disease people. Nora Volkow, the National Institute of Drug Abuse, they're really finding that there are adaptations and changes that occur with chronic drug use. Changes in receptor sites, changes in brain chemistries. So there is a brain basis. But whether we call it disease or habit, there's some neuroscientists that are coming out, have just come out recently with some books. Mark Lewis is one, The Biology of Desire, where he's talking about how brain changes are associated with all learning and all habits. So if the brain changes are habit and learning, we can change habits and we can learn new ways of adapting and coping. From this point of view, we think of addiction then as being an overlearned habit. It's been reinforced many, many, many times. And now I want to talk about multiple meanings. Is everybody with me, or have I lost you? Okay. This is one that I'm most interested in, but we can consider that all of these may have some relevance for some people. From this point of view, it's a way to think about what is the experience? How do people experience their drug use? In what way is it meaningful to them? And as I said before, meanings can be on a spectrum of awareness. It may be that the problem behavior is kind of like a language, that people express something in their behavior that they can't express in words. So that the behavior is actually carrying meaning. It's carrying a communication. It's like when somebody has an argument with their wife and they go out and get drunk. What are they saying to their wife? That maybe they didn't even know they felt, or they couldn't put into words. What's getting communicated? And I think that meanings, that substance use often carries multiple meanings, so that there's meaning that's being carried, being reflected, and these meanings may reside inside of meanings. So that when you ask somebody, why did you get high? And they say, I don't know, I felt like it. Like that's the tip of the iceberg. If we go inside of what was that feeling a reaction to, or what was that feeling wanting, or what was that feeling saying, we open it up. And I was talking with somebody earlier before we got started. In Chile, when I gave a similar talk, the head priest of the organization gave a theological talk about the theological basis for harm reduction. And when I was talking about meanings residing inside of meanings, the need to unwrap the urge, he said, and he added this, which I thought was beautiful, you unwrap the urge like a Christmas present. That there's something vital and beautiful that's living inside of that urge that we need to discover. We need to be able to connect with. So that the urge, the addictive urge, may be camouflaging or keeping something out of awareness that we need to discover. So from this point of view, we would think about addiction as, or an addictive relationship as expressing something and disguising it. So that all you see is the urge. You don't really see what's inside of it. And from this point of view, the entry point to rediscovering those multiple meanings is the urge and the addictive behavior. So from this point of view, we would want to invite people who are actively using into our treatment centers so that we can help them get inside of that addictive urge, make sense of it. I'm going to skip ahead. Well, let me just talk about self-medication. Self-medication was a major breakthrough by Ed Kansian, who suggested that one of the major meanings is that substance is used to care for oneself, to comfort oneself, to manage uncomfortable feelings. And we see that all the time. Maybe also substances are used to manage difficulties of regulating oneself, dealing with your feelings, dealing with your self-esteem, dealing with your relationships. difficulties of self-regulation. And if you guys come to our training tomorrow, we can really get into this in depth. But there are really complex meanings. One of them is a rebellion against the inner critic. You know, we all grew up in a culture, in a family that has certain expectations. We tend to criticize ourselves when we fall short. And often drugs are used to quiet that inner critic, to be free from it, to break out, right? To not feel so guilty and anxious and ashamed. So there are these complicated dynamics that get played out with the drug. Identity, interpersonal communication, bonding, and trauma. I have to say a little bit about trauma because the research is accumulating that a huge percentage of people with problematic substance use have histories of trauma of various kinds. It comes from the Adverse Childhood Experiences study. They looked at 10 different adverse experiences, and they found that the more of these experiences people had, the more severe behavioral problems they had in many areas: substance use, teenage sexual behavior, early smoking, health problems. So trauma seems to have a profound impact on many areas of people's functioning, including substance use. 50% of all people who seek substance use treatment suffer from PTSD. Van der Kolk says a maltreated child is up to 12 times more likely to develop addiction. So the data comes from all sorts of places that we need to be thinking trauma, at least considering it as a possibility when there is significant problematic substance use. And this statistic is just mind-boggling. Addicted women have higher rates of intimate partner violence, 87% compared to 28%. Rates of sexual abuse in the general population are identified as 15 to 30%, but in the addicted population, the rates are as high as 85%. So trauma, trauma, trauma. And this is one way that I think about it. Trauma contributes to dissociation, that is cutting off from your experiences, your feelings. That in turn contributes to difficulties in regulating feeling states, feelings of shame, guilt, mistrust, and all of those symptoms render people vulnerable to using a substance in an attempt to self-medicate those symptoms. Okay, and finally, I want to make some statements about social determinants, because we've talked about bio, we've talked about psycho, and now we should think about social determinants. The legal context can have some impact on reducing the incidence of substance use. So alcohol beverage control laws, are very valuable. Laws against driving under the influence limit, that behavior. Minimum purchase, etc. However, the criminalization can lead to guilt and shame and anxiety. So in some ways, laws may help, and in some ways, laws may exacerbate the problem. The economic context, the pricing, restriction on opiate prescribing increased the price, but then it made it less easy for people to get the prescription opiates, and more people turned to illicit heroin. The normative context, social attitudes, glamorizing drugs, stigma. And I think that stigma is one of the key issues that can contribute to shame and guilt and anxiety around drug use that exacerbates people's drug use. And the physical aspects in terms of, psychosocial or socioeconomic conditions of poverty, homelessness, etc., can have a profound impact on people's vulnerability. So what do we do with all of this? How do we put it all together? And this is how I make sense of it. Let's consider that for each individual person who's struggling with substance use, there's some combination of biological, psychological, and social vulnerabilities that interacts in a way that's unique to each person. For some people, there's more genetic loading. For others, there's more family dysfunction. For others, there's more psychiatric illness or trauma. But so, if we consider that there's not one cause, maybe you've heard this term, many paths to addiction, which then requires us to consider many paths to recovery. So there are many vulnerabilities that may interact in a way that's unique for each person that creates this experience of a fit. When I took that substance, it seemed to help, it seemed to click, it seemed to fit with my vulnerabilities. The substance use was pleasurable, or it was rewarding, or it helped in some way, such that I wanted to repeat that experience. And in that context, it became very meaningful. It took on multiple meanings, as we were just talking about. As people use over time, the substance then takes on multiple psychobiosocial consequences, which exacerbate. And here's where we see receptor changes, biological changes, but also the influence of social context. If you're a person who's finding drugs helpful for your depression, and yet you also know that it could risk, you losing your kids, so you need to go into isolation, you need to hide out, you can't seek help, all of that may contribute to feeling worse. And then the increase in drug use. So we see this process set in motion. But the question is, now we're into really complex waters, and what do we gain from this complexity model? So if the substance is really helping in some way, even while it is increasingly problematic, it seems to me somebody may be highly ambivalent about change. And that's the kind of situation that typically walks into our offices. Folks are probably, many of you are familiar with the motivational stages of change or trans-theoretical model. This is a model that I find extremely useful because it really lays out that there are maybe many stages that people need to go through before they get ready, to move into action. Oh, I just realized I have a little thing here, although the thing might not work. So, for the folks that are using and the substance is working and they're not really connecting it up with negative consequences, they're going to be in what we call pre-contemplation. I'm not thinking about stopping because it's actually helping me. But once people become aware of negative consequences, they now may be pushed into contemplation. My wife is threatening to leave me if I don't deal with my drug use. That's creating a conflict that may have me now thinking about, do I need to stop, or what do I need to do? So now we're in contemplation phase. But there may be lots and lots of things that people need to work out before they come to an idea about the change that they need to make. And when they have that idea, they may move into a preparation phase, which is oriented toward what change do I need to make? How am I going to go about making that change? Do I need to go to rehab, to detox? Can I go to NoBox? Can I do it as an outpatient with therapy? Can I go to my church? Maybe my pastor can help me, or should I bring my family into it? There are all of these questions that come up around preparing to make the change. And once you've really figured all of that out, and you've got a plan and solution, now you can move into action. So this large group of folks at the bottom here are the folks that are going to be active drug users, concerned about their use, using for complicated reasons that need help where they are. And that's what I think is the basic theoretical rationale for why we need a harm reduction approach. That is, one that will invite people into the room with their conflict, with their drug use, with their wish to change, but without a clarity about how to do that. Maybe we can come back to Mary later. She's a great case example. But so finally, the treatment implications, and then I'd like to throw it open to some discussion again. So from this point of view, we want to deal with the substance use and all of those complex, highly unique mix of issues that are unique for each person in the same room. That's one of those shifts from deal with your disease first and then deal with everything later. Well, if they're all intimately intertwined, we need to deal with everything in the same room. Maybe with a whole team of people, specialists, that can deal with different aspects of the issue. The vulnerabilities and the consequences may need to be identified and in some cases resolved before the person is going to feel motivated to take on the substance use directly. Think about my patient I mentioned at the beginning, Valerie. She needed to come in and have her trauma identified and resolved to a great extent, and then she became very motivated to stop the substance use. Addressing any issue in that system is going to shift people's motivation. So here's a very simple and very powerful example of that. We're now in the United States experimenting with wet shelters, that is, inviting homeless people into a shelter who are actively drinking or using drugs. So that there are some rules that you can't use in a way that will endanger other people, but in the privacy of your own room, you can use. And what they find is that mental health goes up and substance use goes down without any other intervention. So if you take the homelessness piece out of the equation, that's going to shift people's relationship to the problem behavior. Now think about all of those complicated vulnerabilities and consequences. Maybe we can develop a treatment that will address many of them, even if the person isn't ready to address the substance use. And in many cases they are, but maybe not ready to stop. Thus the need for a treatment that will appeal to and accept active drug users, and that's essentially what the harm reduction framework is oriented toward doing. So maybe we can throw the mic around or invite people to raise questions, make comments. I'm wondering, is this new to you? Is it disturbing to some of you in the room? I did a training a few years ago, and one of the women got up in the room and she said she was really angry at me that this was, so at odds with what she had been taught, and she couldn't figure out if it made any sense. But I think that when we're talking about shifting lenses, shifting paradigms, it can be very disturbing. I sometimes sit in the room with patients and I still have, we're opening the door to working with people that are engaging in very risky behavior, so no doubt it's going to be challenging to the clinician. In fact, that's one of the things that abstinence-only treatment does, is it limits, it self-selects people that are willing to do it our way. Those are nice patients to have, But the people that don't want to do it our way, the more complex people, challenge us as clinicians in many, many ways. So we're opening up, sort of a can of worms of clinical challenges. So I wonder if anyone...
Does anybody have a question? Please identify yourself and your affiliation. We have 10 minutes for this one.
Mine is a comment. I love your lecture, Dr. I'm Pilar Ramos Jimenez. I used to be a professor myself, and this is a very clear example of complexity theory, a complexity theory that makes it so clear that we understand through harm reduction the need for a transdisciplinary approach in dealing with such an issue. That it is not just the domain of clinicians, but it brings in all the disciplines to work together on something that we can do something about. Because this calls for policy change, this calls for decriminalizing drug addiction, because we have always looked at them as criminals, and so there's no access to drugs, and then you have all the drug dealers, no treatment, and so therefore we should come together, not just as, as a people with varying perspectives, so that we can deal with this issue. And I love your lecture. I would like to have you in my class, in our school, because this is what we do for health social sciences. It clearly demonstrates that health is a complex thing, but has to be dealt with in a much broader and transdisciplinary perspective. Thank you.
I'm glad that you're doing that work, and I'm sure that many people in the room are also doing that.
Next question, please. Yes, ma'am.
I'm June Lopez. I'm a psychiatrist from the University of the Philippines College of Medicine, and I also very much appreciate the opportunity to be here. I've been a practitioner of psychiatry for, I hope I don't look it, 40 years now. And I must say I have mixed feelings of hearing something different, especially in the way you call this new paradigm, but at the same time feeling that there's really nothing new. Because, well, particularly in my school of thought in our department in the University of the Philippines, we are for the psychosocial, biological, spiritual approach to any kind of behavioral and psychiatric problem. And as I've experienced drug addiction, not as an user, but as a therapist, and also had a chance to be exposed to the American way of the Alcoholics Anonymous, or very expensive places where you have your celebrities go for their recovery. The movement from the very spiritual powerlessness approach that you mentioned to the medical model seems to be really pushed by what seems to appeal to people, both for users and for the families. To feel powerless is to surrender yourself and accept the help, ask for forgiveness, which I saw worked in that very expensive drug rehab recovery I attended. And for others, it's being told that it's a medical problem. It's not your fault. It's not your choice. It can even be genetic. And in that sense, alcoholics, patients I know and friends I know have been into alcoholism were very much helped by the idea of the medical model. And now the spiritual approach is something else, because as you said, I agree that the powerlessness model lends itself to being victimized by people who would sell a certain way to heaven, and that there is such a thing as spiritual bypassing, that through prayers, through church going, you will solve everything without going through a grounding for the psychological roots of your problem, which is our work as psychotherapists. So I don't know, it's a long prelude to my question, what makes harm reduction psychotherapy any different?
Thank you. In a way, and I said this in my book, this is just good treatment. The thing is, the reason why I think we need a name for it is because most of what happens in the field is not good treatment, but accepted as the law of the land, or the one truth. So I think we need to name it as something different from the old school. And right now that name, that banner, is harm reduction therapy. And what that means is, in a nutshell, what you're talking about: individualized, personalized, respectful, compassionate, empowering. And to then pick up on the second point you made, I think that all of those models work for some people. I have family, friends, colleagues, and patients that have found Alcoholics Anonymous to be life-saving. So I say that's a wonderful thing for some people. The problem is that some people around Alcoholics Anonymous want to proclamize or proclaim that it is the one truth for everyone. Similarly, the disease model. Some people find that to be tremendously useful. And of course, it has spawned, research into life-saving medications and, things that can be helpful. But it's not helpful for everyone. And others find the learning model, the overlearned habit model, to be tremendously valuable. So my thought is that this framework is kind of like a trans-theoretical or an a-theoretical model that's really designed to create a space for us to figure out with each patient what theory, what model, and what treatment, blend of interventions is going to be most useful to that patient, which is good clinical practice in medicine and psychiatry, but unfortunately has not been, the norm in addiction treatment practice. So, however, so that's my thoughts about that. Yeah, maybe another comment, question or two, and then we'll take a 10-minute break, and we can all stretch a little bit.
Good afternoon. I can really understand the integration between harm reduction and psychotherapy. I'm from Cebu City, and for many years we have been doing the harm reduction program as in the context of prevention of HIV/AIDS. Our main goal during that time is really to prevent transmission of HIV without addressing the drug issues. But I understand that we cannot really continue doing the harm reduction without addressing also the drug issues. That's why I'm very happy with the operations research that was approved by the Dangerous Drug Board, wherein there's an integration with the harm reduction as well as addressing the psychotherapy approach for addressing the drug issues. Unfortunately, as mentioned, the harm reduction that includes needle and syringe program is really against the law. That's why it's a very big challenge as of this moment. But I agree that it's very important to integrate the harm reduction with the psychotherapy, addressing drug issues also.
Thank you. I'm glad you mentioned that, because that's another one of the splits that I think is a global split between the harm reduction community, which has been more organized around HIV/AIDS, disease prevention, helping people stay alive and safe, and the drug treatment world, which has been more abstinence-based. And you'll see in a slide when we get into treatment that this is another way that I've conceptualized harm reduction psychotherapy as bridging, sort of bringing a therapeutic orientation to harm reduction settings and a harm reduction orientation to treatment settings, so that we can actually create, a whole continuum of care for people at every step along that spectrum of need. So it's 4:30. Maybe we should take a 10-minute break now, and 10, 15 minutes, but really 10 or 15 minutes. And then we'll come back and we'll get into harm reduction, the harm reduction world in more depth.